So if there is no question from audience, we move to next talk, that is keratometry, and Dr. Tanu Singh. Dr. Tanu is assistant professor in our department, and she has been instrumental in making and this finalizing scientific program of this PG teaching.
Very good morning, everyone. So let's move on to the basics of keratometry. So as you know, cornea is the most powerful refractive component of the eye, contributing to around 3/4 of the total power of the eye. The shape of the cornea, as you can understand, is a prolate ellipsoid. So it is steeper in the center and gets flatter in the periphery. And it is because of this curvature that gives the corneal power or the corneal power, the refractive power to the cornea. So measurement of this radius of curvature of the anterior surface of the cornea is known as keratometry or ophthalmometry. Okay, going a little bit into the history. So it was in the 17th century that Scheiner gave the idea of measuring the corneal curvature. Ramsden was the first to invent a keratometer in the 18th century, but for clinical use, the keratometers that came into vogue were only in the 19th century, separately by Helmholtz and Jawal and Schwartz. Autokeratometer came quite late, in only 1980s. Just briefly about the principle of the keratometry. So all the keratometers, they basically assume that the anterior surface of the cornea is a perfect reflecting spherical surface. And if we could measure the size of the image that is formed onto that surface by an object of a known size kept at a known distance, then we can measure the anterior radius of curvature with this particular formula. So the major hindrance in this measurement was that even if we would ask the eye to stay still, there would be some micro movements and the exact measurement would be an issue. So in order to overcome that, prisms were incorporated into the keratometers, and that would lead to doubling of that image. So with every movement, both the images would flow together or move together, and that would make the measurements more accurate. So we could coincide the images onto each other, and that would help to have a more precise measurement of the image. And this concept is known as image doubling concept. As you know, keratometry can either be expressed as in millimeters, which is basically a measurement of the anterior radius of curvature, or it can be denominated or told in dioptric powers, which is a more common form of telling you about the corneal power. So this is the particular formula, and it takes into account the refractive index of 1.33, which is basically a standard that is being taken, which also try to compensate for the posterior corneal curvature, but it is not specific for each eye. Okay, so it is just a general refractive index that they've taken into account. Otherwise, the refractive index of the cornea is 1.37. Okay, so coming on to the types of keratometers, so we have manual variety and we have automated. Manual that's available is Bosch and Lomb, Jawal Schwartz, and by Zeiss. Automated can be a separate autokeratometer, or it could be a part of refractometer called autokeratorefractometer, or keratometry can be obtained from the automated keratometers that's incorporated in your biometry machine, like your IOL master and LensStar. Also, you can have your keratometry readings from the corneal topography systems like your Pentacam and OpsCam. So coming just briefly about your manual keratometer, so we have the major varieties that's available is Bosch and Lomb and your Jawal Schwartz. Bosch and Lomb is also known as one position keratometer because already the axes are perpendicular to each other and you don't have to rotate the system to measure the second axis. Two position keratometer is your Jawal and Schwartz keratometer. Here the system has to be rotated to measure the second axis. Okay, this is known as two position keratometer. So this is the most commonly used keratometer, which is basically a Bosch and Lomb keratometer. So once you've made the patient sit comfortably by adjusting the forehead rest knob, the elevation knob, and the chin rest knob, what you can see through the objective lens is something like this. Okay, so you have to pay attention to the right lower circle. This is the circle with the crosshair. So the first step would be to get this circle into focus. So using the focusing knob here, you can see here, the first step would be to get this particular circle into focus. Now once this has been achieved, you lock the system with the help of the locking knob. Okay, and now you are ready to measure your both the meridia. So you have your horizontal measuring drum and your vertical measuring drum here. So you move your horizontal measuring drum and try to superimpose these two plus signs. Okay, and this would be your endpoint where both the plus signs have been superimposed, and then you take the reading of whatever the drum is showing. Okay, then you move your vertical knob and try to superimpose the minus lenses, and then again you take the reading. So ideally you should take 3 pair of individual readings and take an average of it. That would give you the exact keratometry readings. And by convention, K1 is the keratometry reading of the flatter axis and K2 is of the steeper axis, and the difference of the two will give you your astigmatism. So there were few limitations of the manual keratometry. First, that it assumes that the cornea is a perfect sphere. Okay, so it has limited value in testing irregular corneas. Also, the mires that were formed are reflected from 2 separate apertures on either side of the instrument, which are separated by 3 mm. So the central zone is basically neglected altogether. Also, the 2 readings of the same cornea is going to be different when measured with different keratometers. So these were the major limitations. Also, if you look at the range of the keratometer, it measures from 36 diopter to 52 diopters. So then came the concept of extended keratometry. So you need to know these terms. It can be asked in your exams. So in order to measure steeper corneas, you can add plus 1.25 spherical lens in the front of your objective lens, and that would increase your range to 61 diopters. And for flatter corneas, you can add minus 1 diopter spherical lens, and that would increase the range to 30 diopters. Now coming on to the automated ones, I'll talk about the ones that's been incorporated in the biometers. So first is your IOL master by the Zeiss group. It takes into account 6 reference point on the anterior corneal surface within the optical zone of 2.3 mm, takes a series of keratometry readings and give you the final keratometry reading. Then we have LensStar, which is by Hackstreet. It takes into account 32 reference points which are arranged in 2 circles, the inner one being 1.65 mm optical zone and the other one being 2.3 mm. And you get something like this. This is the sheet. So here you can see the central zone will give you the keratometry readings. So you have flatter reading, the steeper reading, and the difference, that is your astigmatism. And here you can see the keratometric index that they have used for the conversion of the dioptric power is 1.33. Okay. Apart from this, you can see a series of other things or parameters that have been displayed, which includes your corneal thickness, AC depth, lens thickness, and so on and so forth. So this is one of the major advantage of the optical variety, where you get additional information apart from the keratometry reading. It is quicker with a shorter learning curve. It has a good inter-examiner repeatability. Disadvantages, as already been mentioned, is that being a light dependent investigation, optical opacities along the visual axis would be a hindrance in getting you an exact keratometry. Also, if the patient has poor cooperation, is not focusing well again. So major source of error would include poor patient positioning or fixation, improper focusing, accommodative fluctuation. Also, keratometry readings will be erroneous, or you won't be able to see sharp points if patient is suffering from dry eye because of the dry spots. So make sure that you're instilling a good amount of lubricant before you take up the patient for keratometry assessment. Okay, so dry eye, meibomian gland dysfunction, any anterior surface corneal diseases, or excessive tearing again is going to hamper the keratometry readings. So where do we use keratometry? In order to measure the corneal astigmatism, for IOL power calculation, to estimate the base curve in contact lens fitting, to assess the refractive error in cases of para or central hazy media, and to assess the pre and post surgical astigmatism. So first would be measurement and classification of corneal astigmatism. So can anyone tell me, in the first example, what would be the astigmatism? Any takers? Fast. क्या है इसमें? Only you have to minus it 2. Along which axis? Which axis is steeper? 90. So that would give you which type of corneal astigmatism? If with the rule or against the rule? Yes. So if my vertical axis is steeper, it is with the rule astigmatism, right? So the other example you see here, the astigmatism is 0.75 along 180 degree. That is your horizontal meridia is steeper. So it becomes against the rule astigmatism. Anybody who would like to tell me what is oblique and bi-oblique astigmatism? So between 30 to 60 on one axis and the other being 120 to 150. But the relationship should be, they should be perpendicular to each other. And once the axes are not perpendicular to each other, it becomes bi-oblique astigmatism, right? So the next application would be for IOL power calculation. So one thing that you need to understand is that you always take average of your keratometry reading. It is not K1 or K2, it is the average. Second, you need to understand the relationship of keratometry. So you see it is 0.9 times the keratometry reading. So almost one entire diopter is going to get affected, and that would lead to post-operative refractive surprise if we have made any if we have not calculated the keratometry readings properly. The next would be to plan your incision, right? So whenever we are making an incision, we are flattening that particular axis. So if we know the astigmatism beforehand, we can plan our incisions that would help us to correct around 0.5 to 1 diopter of astigmatism. So if we can see here, there is astigmatism of 1.16 at 85. That is somewhere around, it's superiorly, right? So it is along the vertical axis. So in this case, we would attempt a superior incision, right? In the other example, if you see, the horizontal axis is steeper, so we can plan a temporal incision for this case. The next is we can also plan our limbal relaxing incisions, which can help to correct around 1.5 to 3 diopter of corneal astigmatism. So we can make these incisions in a coupling fashion. So we have to make 2 incisions along the steep axis. So that is going to relax or flatten the steep axis. At the same time, it will steepen the opposite axis. Okay. So this is your limbal relaxing incisions. Special conditions where keratometry reading is absolutely not possible in cases of very dense corneal opacities, or in cases where we are planning a triple procedure. So in that case, if keratometry reading is not possible to take, what we can do is, and we have to plan an IOL implantation, we can take keratometry of the unaffected eye, or we can take a standard keratometry of plus 44 diopter. The last slide, so something, another term that you need to know, something known as conventional keratometry versus total keratometry. So conventional keratometry, in all the examples that I've shown you and all the keratometry that we do, we take into account only the anterior corneal surface, okay? But we know that posterior corneal surface also has some power to it, right? So that is not taken care of in most of the standard keratometry that we do. So the newer variety of optical biometers that have come, that includes your IL Master 700, which is based on swept source OCT parameters. There it also takes into account both the anterior and posterior corneal curvatures, and it gives you a corrected or a total keratometry value. So this is the concept between conventional and a total keratometry. So you need to know these terms. So that's all from keratometry. Thank you.
Looking after cornea services. So she'll be speaking on IUL formulas.